Hello and welcome to Pain Unfiltered, where we go in-depth into the interventional pain and spine world with some of the top key opinion leaders and executives in the space. We are your hosts, Dr. Patrick Buchanan and Dr. Timothy Deere for this Aspen podcast. Let's get started. Hello and welcome to the Pain Unfiltered podcast. I'm your host, Dr. Patrick Buchanan, and with me is my co-host, Dr. Timothy Deere. Tim, how you doing today?
Patrick, I'm doing fantastic. I'm a grandpa now, and things are good. So it couldn't be better, and it's good to be here with you. And having two fantastic guests today makes me so happy. So look forward to this conversation.
Well, congratulations, Tim, and happy Father's Day to you all as well.
You too.
We would like to thank our third sponsor of the season, Mainstay Medical. We're excited to have their CEO, Jason Hannon, on, and also Dr. Kiran Patel on next episode to discuss Mainstay's journey to commercialization. So look out for that episode as well. We'd also like to thank our other Season 3 sponsors, Saluda Medical and Spinal Simplicity. We really appreciate you all for supporting honest and unfiltered conversations. So, Tim, today we're going to turn our attention to treating our veterans, the men and women who have sacrificed so much for our country. And I know, Tim, you're close with this with the Navy SEAL Foundation as well. We can discuss that as well. But today we have two interventional pain physicians that have had a tremendous amount of experience treating our veterans. And joining us today is Dr. David Reece and Dr. Gabriel Pagani. Guys, thank you for joining us today.
Thanks for having us, Pat, Tim. Great to see you guys.
Welcome. Welcome.
Very excited to be here. Thank you.
Perfect. So we'll just start off with you guys just talking about just your brief background and any disclosures you guys have. Gabriel, we'll start off with you first.
My name is Gabriel Pagani. I'm a pain physician of a neurology background. I live in Cincinnati, Ohio. I practice in a few practice settings. One is the Cincinnati VA Medical Center. I also practice at a community hospital, a critical access hospital in Hillsboro, Ohio. Disclosures to mention, number one, I'm here in my own kind of private sector individual capacity. I'm not representing the views of the VA. I don't have the authority to speak specifically on behalf of the VA. And I am also a consultant for Spinal Simplicity. So, everything I share today is just all about the veteran patients that I've come to know and my time both in the VA and also in the private sector.
Great. David?
Awesome. Yeah, guys, hopefully, obviously you know me, but for the rest of the crowd listening, for the purpose of tonight, the Director of Neuromodulation for Absolute Pain Management in Rockville, Maryland. As far as my history in treating veterans, I've been the Chief of Physical Medicine and Pain Management at Walter Reed National Military Medical Center for over 8 years. I've had experience in deployed settings in Afghanistan, and then obviously working in concert with ASPN with an Armed Forces division that Gabe Pagani is a part of, and thanks to Tim and Dawood and the rest of the ASPN leadership for supporting that mission as well. So happy to be here and talk about our experiences. And as far as disclosures, again, not speaking on behalf of DOD, VA, Defense Health Agency, or any of the medical units associated with the military.
A great introduction. I just want to start off with a kind of a simple question to start off for both of you, and I think we'll just kind of throw the first few questions at both of you and then maybe go specific to each one of you. But, Gabriel, my grandpa was a medic in Normandy and drug a lot of people off the beach and somehow survived, which was kind of amazing. I think he was on a little bit later wave or I wouldn't be here today probably. But, I know that there's been a long history of veterans needing care. And here in West Virginia, we often send folks to see us who maybe at the VA they don't have some option we may deliver like Minuteman or Liberty. How did you get into pain management? I know you're a neurology background. How did you get into pain management? And then how did you find yourself treating veterans?
Great question. And, I don't want to give too circuitous an answer, but basically a series of accidents and missteps has me where I am today. And I'm very happy to be where I am. But yes, I went into neurology with the thought of doing endovascular neurology, yanking clots out of blood vessels, and decided that was maybe a little too intense for me. And I discovered about pain management completely by accident. I was not even aware of it being a specialty as a medical student. As an intern, actually, before even my neurology year, we had a patient who was struggling with spinal stenosis on a PCA, too sick for formal open decompressive spine surgery. And the pain services consulted and actually performed a percutaneous image-guided lumbar decompression for her, and it actually helped her out tremendously, honestly. And I was so interested in it, I followed her chart throughout my intern year, keeping tabs, and she continued to do well, and I was kind of hooked. The ability to just in a very minimally risky fashion help people is just extremely powerful, and I think that's one reason why a lot of us went into medicine. And so, it was basically a calling for me. It was natural that I would gravitate to that specialty. And veterans, I always loved working with the veterans. Even as a Stanford undergraduate, I would volunteer at the Palo Alto VA. I've always been drawn to the type of characters who would just sacrifice like that. And I just an opportunity arose in Cincinnati. I was transitioning between practices, and there was an opening at the Cincinnati VA, and I took it. And one reason why I've continued, frankly, to treat veterans and at the VA setting and the private hospital setting is that they are just a remarkable population of individuals to deal with. There's kind of no better patient out there is how I feel. They're grateful, and they have a long history of service, and it just I guess this is a selfish answer, but it just feels good to take care of them. And
Great thoughts, David.
David, we'll ask you the same question as well.
Yeah, joining the military was a little bit different. I think selfishly, again, probably they paid for 2 years of med school. But when I look back, that 2 years when med school is 4 years and then you pay back, it's been 15 years later and I'm still active. It's like, well, hey, it's more than just, hey, they paid for med school clearly at this point. And I agree. Second, Gabe's comments, this is a patient population that bands together, team of brothers, whatever, no sisters, ever, not to be, singling any race, any gender out, but they all, an army of one, and I am going to single out Army, not just Navy and Air Force because I am Army, but for sure we're all kind of comrades, and just understanding how everybody's always looking out for each other. I think even in residency it was like that because my residency was at Walter Reed as well in fellowship, and so just everybody's looking out for each other. You got somebody you can bounce ideas off on. You got really esteemed upper level staff and attendings that have all experienced some really extreme care and extreme conditions, in theater environments, and then also under duress. And so I thought it was a great environment to train in, and also to learn, medicine, the way medicine really should be practiced, and not with the direct pressures of insurers and all these other barriers. Of course, we have our own logistical bureaucratic barriers in the DoD and VA settings, but we, by and large, can practice, the way medicine, the way it really should be practiced, and that's why I stay in the system for now.
Yeah, that's great, guys. I trained also at the VA for residency and fellowship, and I do see patients now as in a private practice setting too. But yeah, it's really fulfilling just hearing the stories, even the war stories at a patient that was on D-Day, a lot of Vietnam vets as well, and just hearing their courageous stories and being able to give back to them of so much of what they give back to us is really quite humbling. So let's go to the next question. We'll aim this towards Gabriel here. What common pain syndromes do you see in the veteran population, and how do they differ from civilian patients?
Well, a spine is a spine at the end of the day, but I feel like the veteran spine, the veteran nerve, has kind of been through a little bit more than the average Joe or Jane. I'm a civilian, so Dave Reece endured all this in his basic training, but I had to learn honestly from these veterans the kinds of things they actually had to do in basic training, and I mean, it's not hyperbolic. Jumping off of planes, several 100-pound rucksacks. I mean, they really kind of traumatized their spine pretty hard in their young years and pay for it later. I have back pain, and all I did was just weightlifting and jet skiing and soccer, and it was a fraction of the kind of trauma that these individuals had sustained. So I don't think it's too shocking that they would be predisposed to spine and nerve problems later. And so it's a 60-year-old vet, but an 80-year-old spine, might be kind of a way of thinking about it. And I guess pathogenesis, why, I actually think a lot of it is tied into multifidus dysfunction, to tell you the truth. I know that's not what we're speaking about today, but I think some kind of repetitive trauma makes the multifidus go offline, and now the entire spine construct is at risk of accelerated degeneration. So that's why I think all sorts of spine problems can blossom in these individuals from, for many, I think it's just from multifidus dysfunction from injury in their service. And, it's not just, these are, warriors and young people and fit people. They get hurt. They're not going to talk about it. They're not going to get seen for it. They want to stay in the game, so it is often an injury that is not treated adequately with rest either as part of the ethos that they have. So, I mean, in summary, I don't think there's any kind of zebras out there that are more common, but I think it's just a lot more traumatized spines. And, there's a lot of the, advanced degeneration happening earlier in those folks.
No, great thoughts. I like that answer a lot, Gabriel. I think it's a fantastic insight. David, years ago, you may remember this. I'm not sure. I think you were probably a fellow back then, but we implanted a lot of people from Fort Bragg at the time with spinal cord stimulation who were able to return to duty. And it was pretty surprising because I think people thought that would never be possible. Some of these folks who've been injured in Afghanistan and Iraq early on in the first parts of that war. And now we treat a lot of folks that are TRICARE, that are active duty. We treat people that are from the VA. And we see a lot of people now that they're candidates for things like Minuteman because they have, they may have comorbidities. They may not be good candidates for larger fusions. And quite frankly, younger people don't want the larger fusions anymore a lot of times if they're grade 1 spondy. So what's your experience with the military population and things like the Minuteman procedure for stenosis and Liberty for SI joint dysfunction? What's your experience there as far as the active duty versus the VA patient? Are you able to offer those therapies to the groups of patients?
Yeah, absolutely. And I think the setting that the veteran provider is going to be practicing in is going to dictate kind of the primary demographic that they're seeing. In an active duty population, particularly like a Fort Bragg or Walter Reed, you're seeing the at 18 to 45, 50-year-old colonel or master sergeant, right? And so, are they directly necessitating, an interspinous fusion device off the bat? Probably not, at that age. But as they get towards that latter end of their career, they may. And so we predominantly see that younger demographic, at least at Walter Reed, being active duty only at this moment in time. And so those patients tend to take the brunt of basic training activities, jumping out of planes, like you said, Gabe, and we'll see a lot of degenerative disc disease and SI joint dysfunction earlier on than probably most of the civilian sector. And so to the first part of that question was SI joint and spinal simplicities system. And I think they have a really unique system that when we look at some of the other lateral approaches that are out there that are much more invasive and riskier, I think this is a great option for them. And particularly in our setting, when we talk about return to duty, when we have injections and RFA, we can still do that in our setting. But we all know, I think that's not a durably efficacious procedure, for long term. And if we're trying to send somebody or keep somebody in service, we want something that can give them some durable efficacy. And I think Simplicity has a good system for that. And so that's definitely appropriate here in the setting that we treat in the VA cross settings. I see patients not just from the active duty sector, but I see the VA patients from local VAs and even across the country through different fashions. And so I am seeing some of those older demographics where interspinous fusion is important and they are much more approachable. These patients hearing about something like a Minuteman versus having, multi-level fusions when it might not even be necessary, and it can get them on to, 4 or 5, even more years before they really need something more invasive. So we do see it, and I think it's effective. It has been effective in our demographic in the veteran setting. It has helped people stay and return to duty. Being potentially boarded out of the military is a big deal for a lot of these guys that have dedicated their life to service. And if they're right at that tail end of their career, and somebody's telling them they're going to get out, if they they either get this multi-level posterior spinal fusion or they're boarded out, that's a big deal. And so when we can offer them something less invasive and keep them in service and let them finish out their time, people come to tears with that option. So glad to be able to offer it.
Great.
Yeah, great explanation, David. I think we're very fortunate in our field right now to have so many different tools at our disposal, specifically the minimally invasive ones that veterans can respond with. And Gabriel, we'll turn it back over to you. Can you walk us through one of these patients with degenerative spine disease, spinal stenosis, neurogenic claudication, and kind of what your algorithm is, and working them up, and maybe having an option for an interspinous device like a Minuteman?
Sure. Well, step one before we kind of delve specifically into the biological treatment is to make sure we're not neglecting the kind of psychosocial treatment. Veterans have a lot of complex trauma. Uh, Often, sometimes it's not even service connected. Sometimes it even predates joining the military to begin with. So, treating the whole problem is step one. So step two, you're not worried about that or those issues are being addressed, psychosocial issues, is to, you know, come up with an actual pain generator. So I think areas where pain physicians, including myself, um, were maybe lagging previously is not paying enough attention to structural spine disease. You know, and in fellowship, we did a whole lot of spinal cord stimulation. We didn't really treat any structural pathology of any kind. And that was just kind of the way where the field was. And now the field is advanced, so we can neuromodulate and treat structural spine problems. And not only does that make our patients better, but it makes the one procedure is going to help with the other procedure, if you know what I mean, salvaging and whatnot. So I pay a lot more attention to structural spine disease before, considering someone for neuromodulation, and what that would involve is flex X, spine X-rays, really subtly looking for instability on your own, and putting your eyes on those plain films, and not relying on the radiologist's read, because many times things that are noticeable to us are not of interest to the interpreting radiologist. So the kinds of instability that could benefit from interspinous fusion devices, not only the classical translational instability, spondylolisthesis, but any dynamic change in disc height, flexion, extension is an example of vertical instability, and any kind of yawing of the disc, meaning the angle the vertebral bodies make on one another as you move into flex, and X is an example of angular instability. And a patient can have instability without having any of those features, and that's called a micromotion instability, and that is shows up as a lot of facet fluid signal increase and abnormal T2 hyperintensity in the facet joints. So if you basically, I guess an algorithm is there a structural, first of all, is a spine or SI, right? If it's a spine and not the sacroiliac joint, which could lend itself to something like Liberty that was brought up earlier. If it's spine and there's instability, likely the benefit veteran could benefit from treating that instability. And, and where something like a Minuteman becomes useful is when they particularly have neurogenic claudication and relief and forward flexion. Those are kind of some slam dunk, history prognosticating factors that would lend itself to interspinous fusion. So
Gabriel, when Patrick posts this episode on LinkedIn, I would really appreciate in the comments if you go on and talk about. I just love how you explained the types of instability. I don't think most of our colleagues understand that. You have everybody's looking for spondylolisthesis grade 1 or grade 2, but you explained it quite well with the disc height changes and the facet fluid on MRI. So when you go, I'd like to go in the comments section when Patrick posts this and
sure.
just give the three things you just said, because you said it so articulately. I think that a lot of people will learn from that. So thank you for that. I think that's something that we all should be looking for. And you have to look at your own x-rays to see that, because the radiologists will miss that. So I love what you just said. I think that'll help a lot of patients, because I think over half of our colleagues don't know those other two things. They only know about spondylolisthesis on flexion extension. And it should be seated flexion extension as well. And then on MRI, I'm looking for that facet fluid, which a lot of times is missed by the radiologist, as you know.
Yeah.
So great explanations there. Thank you for that.
Of course, thank you.
David, I want to get to return to duty just quickly here. I think the importance of it. I don't know if I think I've told you this story before, but I'm going to tell you a story that, and Patrick knows I kind of go on tangents sometimes. Sorry, Patrick. I'm going to tell this story here. It's a true story. It's a sad story. And then I'm going to follow up with two questions for you, because, Return to Duty is a great charity that, Aspen's always believed in giving back. Ever since I started any meetings for the last 30 years, we've always given some money to charity. 5K run. We have a nighttime benefit for charity. And this year, your charity is one of those charities. So I'm going to give you a chance to talk about that a little bit. But I want to tell you about a patient, and I have a question for you. Then I want to talk about your charity a little bit. So I had a patient back in those days I talked about. He was an Air Force navigator. He had an injury in duty. He ended up in West Virginia seeing me. He'd been in Dayton, Ohio, and I had done a procedure on him that worked quite well, and his pain was extremely well controlled. And he wanted to go back to duty. He was a young man, and his whole lifetime goal had been to be an Air Force navigator. And he'd been there, and he'd done well at that. And he goes back to Colorado Springs, and the doctor doesn't clear him to go back to duty, and he disables him. And the young man went home and wrote his mother a letter telling her how he felt totally normal and that he didn't want to live anymore and shot himself. It was the only patient that I ever personally had kill himself in my whole practice. And the mother called me and shared it with me, and we cried together. And she went over this terrible story. And I thought to myself, it would have been so hard for that doctor to let him go to duty, but I don't know the answer to that, right? Because I didn't know the rules of the Air Force at the time. So, question one is, tell me a little bit about how we can, if someone who's been injured who would like to go back to duty, how does that process work for those who are not military physicians like me who treat military patients sometimes? And then two is, tell us about your charity you're working with and what that will mean and the opportunity at Aspen to give to your charity.
Awesome. Yeah, thanks. And that's a really tragic story, and as a great segue into where opportunity spawned. With Dave Simons, the CEO, who I'm speaking in lieu of, tonight. But unfortunately and sadly, this story is not just it's not one. It's not an N of one. This happens unfortunately way too often, and that's why these organizations, are hopefully existing for the right reasons. I have a very similar story of a guy when we talk about somebody that's trying to return to duty or versus being med boarded out. Severe degenerative disc disease and multi-level facet arthropathy and the whole nine. And he'd been on chronic opioids, diverted to the civilian sector. Nothing bad about the civilian sector, just in general, he left our system because he didn't have access to near the location where he was, that was in like Arkansas somewhere. And so he ultimately makes his way back to Walter Reed for treatment. But he's on 60 TID of OxyContin. He's on a bunch of Dilaudid PRN, and he's in a way worse shape than when he had left and had been deployed overseas. And so the first step was really trying to get him off of this medication and find a way through interventional methods, injections and therapies, to find a way to get him down. And we successfully did that with spinal cord stimulation. And he had a great trial, was off the PRN during the trial, and then ultimately went to implantation to the point where we got him off within 4 months of every drop of or every pill of opioid, and was just on a baseline gabapentin. Unfortunately, this guy then signs. So the process is that they then go to their command unit and say, okay, well, after being signed off by a physician like myself, we clear him for duty. Like, he's got these restrictions, and basically the only restriction for him was he can't go diving. He's not a Navy guy anyway, so it didn't bother him and didn't affect his duty in the Air Force. And so I signed off on him, but the flight surgeon, when he got sent over, had no idea what spinal cord stimulation was, and basically gave him an ultimatum. He said, you can either keep this system in and get boarded out, or you can take it out and try and stay on, active duty. And, he obviously calls very distressed me, and I said, I will send me his commander, send me whoever I need to talk to, because we fought for this for the past 10 years about commissionings and such, about with these types of devices, and he probably just doesn't understand the system. Unfortunately, this very young officer was the flight surgeon, didn't want to hear anything that I had to say. And ultimately, this guy was so adamant about staying on duty, flew back, and I had to explant him. And unfortunately, within 6 months, he was back on, he got sent back home to Arkansas, and then was back on opioid medication, and ultimately got boarded out anyway. And so unfortunately, I don't know what happened after that, because we haven't seen him since, and that was probably 10 years ago. But that's a very bad situation, and I hope that everything worked out for him. But it certainly didn't work out for his military career, and something that we had got him back to duty, and just the system kind of had ruined his future in that system, in the military healthcare system. So that's the bad story, but that's the process, and every service is different, whether it be Air Force, Navy, Marines, or Army. They can be reclassed, which is another way of being returned to duty. Just you go in at one we call MOS, which is just their type of service or what profession they're in the military, and they can reclass to a different position that might not involve as much physical activity, and so that's part of this process too. And so there's multiple angles, but but it takes a lot of upfront talk with the patient to understand their goals and objectives. And if they really want to be in, that's my job and that's our jobs, all of our military providers' jobs, to make sure that they are able to stay in and help us and help support the country in any way we can safely. That segues into return to duty, which unfortunately has a very tragic origin with Dave Simons, who is a Special Forces 18 Delta, and his entire crew, who started return to duty at from nuts and bolts. There was no funding. This is a nonprofit organization, and they had a dear close battle buddy and friend that took his life due to pain-related issues and not being able to have awareness or even access to specialty care in his lane, and which is very unfortunate given the lanes that these special operators can access, and the fact that he couldn't see someone like me or any other interventionally trained pain physician in time to avoid him getting a multi-level fusion that clearly, it turns out, was unnecessary, and then ultimately took his life due to untreated and unattended pain concerns. So this network is filled with providers that are trusted, vetted by our own staff, and by Dave Simons and his crew and other physicians as well. So we look to recruit across the country, and part of the ASPN Armed Forces Division is trying to build a network of those physicians that we can rely on for to call on. And so when we have this event, these charity events, it's great to bring VA, DOD, and TRICARE providers. So that's a mix of that VA and DOD flavor. But then also, if they're in a place like Arkansas, and I hate to keep calling out Arkansas, there's no particular reason that I'm calling that out, but in a rural area where there may not be a metropolis or access to a interventionally trained pain specialist, who's that civilian that we can call that's close by if there's no military treatment facility available? And that's what the goal ultimately is, to make sure that network exists so that these patients can get that access and are aware, more importantly, aware of it. Because if they're not aware of these therapies, they're not going to ask for them. They're not trained like us. And even the providers, if the providers aren't aware of these therapies because they can't go out to these conferences because they're busy seeing patients 50 or 60 a day, then we need to be able to get them that information in a succinct fashion so that these veterans are treated appropriately and in timely fashion. So we look forward to Aspen. Tim, thanks for bringing that up. And that charity event in conjunction with the Ironman Foundation on Saturday, the 5K run, and then obviously the event starting at 5:30. We're bringing everybody together, and hopefully everybody is seeing that, has visibility, and could join us and celebrate kind of and support the foundation that is really making a lot of difference, I think, to this point over the past 5 years.
Thank you.
Wow, thank you, David, for your stories. Tim, for yours. Those are very powerful and definitely hit home. I'm definitely interested in joining the return to duty as well. Just let me know what I need to do as well, because I see I'm a TRICARE provider. And for the audience as well, do you have a website or anything that you can direct them to for that?
Yeah. I'm happy to. I can post that on the comments, the Return to Duty website. There's donations available through that. But then also, if there are veterans out there or veteran providers that want more information or want to be involved more closely, we'd love to have you and love to talk with you.
Great. Thanks, David. We're at that point now. We're going to wrap up with our closing thoughts. Thank you guys for both joining us and talking about your experiences with veterans, and also what tools we have like Minuteman and Liberty to help our veterans. Gabriel, we'll start with you. We'll go then with David, and we'll wrap it up with Tim.
Oh, yeah. Closing thoughts. Well, first, I'm going to piggyback off of what Dr. Reece just said. I've been through, I don't know, 4 or 5 maybe of these return to duty events. They are, the intention is to basically have these events at every major pain society. And there's a lot of the major pain societies to try to capture as big a net as we can to bring people into this network. And, Dr. Reece, you've done a terrific job. And I'm happy to continue to support you. And for those listeners out there, this isn't just, he mentioned VA, DOD, TRICARE, but really anybody can go to this event. It's the more the merrier to try to, educate on what the options are for our veterans. More specific to the technology that was discussed on this call, for those of you who are just maybe dabbling or interested in interspinous fusion and sacroiliac joint fusion, I think the advantages of Minuteman is a lateral approach, not a posterior approach. And so that's a quicker surgery, technically a safer surgery, and uh, you violate less of the spine to take care of the job. When you do posterior, and I actually started off doing posterior interspinous before I switched to lateral, so I've done a lot of those. You're taking out supraspinous ligament, intraspinous ligament. You're devitalizing the multifidus. And I think the reason why fusion has gotten a bad name is that in order to fuse the segment, a lot of collateral damage has occurred. And the beauty of the lateral approach with Minuteman is that the collateral damage to the spine is minimized. You're able to accomplish the task of fusion without, leaving trauma behind. And as far as the sacroiliac joint, there's 40 technologies, 4 approaches. But the Liberty screw is a very slick case, and it has the advantage as being the only laterally implanted product that I'm aware of that actually has a compressive phenomenon, and is one of the fusion principles, compressing across the structure is vital. And surgically, it's very similar to Minuteman actually, as far as all of the steps. The only difference is, of course, the fluoroscopy is all different. It's a very exciting time in pain. A lot of these technologies are really allowing us to help patients in ways that we couldn't even do 5 years ago. The field is evolving so rapidly, and Minuteman and Liberty are among the options in the portfolio that are helping patients, veterans, civilian alike. So, pass it on to you, Dr. Reece.
Awesome. Yeah, great comments, Gabe. I appreciate your support and all you've done for our Armed Forces Division and support of Return to Duty. Spinal Simplicity, again, kudos, to their leadership, and they've done a great job with the system, and also support and their support as well of the Return to Duty organization and our veteran providers. I think these are therapies that are again going to be. This is the wave of the future. We're going to need to be very proficient in the utilization and in deployment of these modalities, and make sure that we're training the right people to do the right things. And I think we've got the right system for that. And ASBN's working on some other my son in the background, some other ways to shore that up. And so I'm excited about that as well, and excited about the upcoming conference. So thanks, Pat and Tim, for having us.
So, Gabe, David, thank you so much for your comments. They've been fantastic. I've really enjoyed what both of you have had to say. Just a couple of thoughts. I'm the father of a military spouse, so it's not just the people who serve in the military, it's also the families that sacrifice. So, I think I really appreciate everything that the military folks do for our country. And right now we're in a time of multiple wars in the world, so hopefully we'll stay at a distance, but certainly we understand the importance. Spinal Simplicity, Todd Mosley and his crew, they've donated to Navy SEAL Foundation. They've done a lot of things to help the military, including Return to Duty. So I appreciate that. And, I think Minuteman's been a procedure for us. It's been really game changing for a lot of patients who really weren't candidates for bigger fusions or didn't want those bigger fusions. So I think what Gabe said is really on the spot. So I agree with everything you said, Gabe. That lateral approach makes it very less risky overall, going away from the cord and no major vessels. So, absolutely. We did a Liberty procedure today. And again, once you get those angles, it's pretty easy technique where you're, again, sparing the large vessels and the nerves. So great methods. I think this has been a great episode and look forward to seeing you on Miami. Patrick, you get the last word of the day.
Yeah, again, just want to echo what Tim says. Thank you so much for your stories and your service to our veterans as well. All of this will be at Aspen. It'll be actually a week away when this gets published. So, come join us, talk to us, support the Return to Duty Foundation, run with us, and have fun and network. And like I said, thank you guys so much for joining us. And this wraps up the Pain Unfiltered podcast. Thank you all for joining us.